Good morning, everybody. Today we are discussing about the compositions and the parts of syringes, needles, and what are the contents of LA and what are the different types of anesthetic technique. Last class we already discussed about the mechanism of action of LA, what are the physiologies of LA. So in these outcomes we mainly regarding about that action, history, properties of LA, components and contents of the cartridge and the components of the needle, and compare the different types of local anesthetics. So, what do you mean by local anesthesia? It's a transient loss of sensation in a circumscribed area of the body produced by the depression of excitations of the peripheral nerve endings or inhibition of the conduction process. So, according to the historical background already discussed last time, so again, I am pressure. In 1951, the progress that hydromic syringe they found, and 1850, the Alexander wound hollow metal syringe. The first cocaine they found as a local anesthetic by that Neiman in 1860. Then calculated the action of demonstration they showed in 1884. Their first effective and widely used of slow anesthetic procaine produced by Enhorn in 1905 from benzoic acid and diethyl amino ethanol. So, lidocaine by Lofren in 1948, the discovery of the anesthetic property was followed by 1941, and it is clinically used by TCO. Thereafter, the series of the potential anesthetics soon followed by the wide spectrum of clinical work. So, going on the parts of syringe, there are different types of syringe we are using: metal syringe, aspirating syringe, and disposable types. So the types of syringes are divided into non-disposable syringes, disposable syringe, safety syringes, and computer-controlled local anesthetic delivery systems. Non-disposable syringes like breech loading, metal cartridge type, and aspirating one. Breech loading type with the plastic one is there. Breech loading with the metallic cartridge with the self-aspirating is there, and pressure syringe for the parental ligamental injection and jet injector. Then the other one, the normal one, is disposable syringe and safety syringe. So these are the parts of syringe. You can see this is the plunger what we are pushing the solution. This is the barrel. So the solution inside the barrel, we will push it, and the needle adapter is there, needle hub, and the needle, that is a shaft of the needle, and the bevel, it's angulated one, and the protective cover. So first one is that plunger what we are pushing. Between the barrel and plunger the solution is there, and the needle adapter, needle hub, and the shaft. The last tip is called bevel. The non-disposable syringes, that means breech loading metal syringe type of aspirating syringe, is the most commonly used in the dentistry. Breech loading implies that cartridge is inserted into the syringe from the side of the barrel of the syringe. That way, these are the things we commonly use in our department. Either we can use the cartridge on the top loading or the side type. The needle is attached to the barrel of the syringe and the needle adapter. The needle then passes into the barrel where it penetrates the diaphragm of the local anesthetic cartridge. The needle adapter is removed or sometimes by discarded inadvertently along the disposable needle. So already you've seen in that department what we are using is the ring, thumb ring will be there, the finger grip will be there, in the piston with the harpoon. That means in this area we are placing the cartridge, so it will push that LA solution and the needle adapter. Metallic breech loading aspirating syringes, the more advantages what we are seeing is that visible cartridges we can see aspiration with one hand, autoclavable, and rest is mostly made up of stainless steel and long lasting with the proper maintenance. The disadvantage is the weight, and since may be too big for the small operators, possibility for the infection with the improper care. So if you are not giving the care for that syringes, there will be high chance of infection because sometimes that syringes they are mixed with the blood. We are not properly disinfect the syringe, then there will be high chance of infection. Next one is the plastic reusable aspirating seal. That's most advantage is that the plastic eliminates the metallic and clinical look, lightweight, provide better feel during injection. Cartridge is visible. Aspiration with the one hand, rest resistance, long lasting with the proper maintenance and low cost. That you already seen in the department, but what we are commonly uh, what we are using is that metal one only, and the disadvantage is the size, possibility of the infection with the parts of the needle is bevel, the shaft, hub, syringe adapter, and cartridge penetration end. So these are the syringes what we told, that is one is that metal one, next one is the plastic one. So commonly used one is the metal one, so we can give use that cartridge and dispose the cartridge at a single use. Next one is that the gauge, that is also very important. The gauge of the needle, that means refers to the diameter of the lumen of the needle. The smaller to the number, the greater the diameter of the lumen. So a 13 gauge needle has a smaller internal diameter than the 25 gauge needle. So when you're going to use, which one is more painful is 25 gauge needle compared to 30 gauge because it is very thin. So there is a growing trend toward the use of smaller diameter needles based on the assumption that they are less traumatic to the patient than needles with the larger diameter. So when you're using with the larger gauge needle, so what will happen? That means 25 gauge needle. If you are using the pain on injection site will be more compared to the 30 gauge needle. And also the main most common complication is be the chance of breakage will be more in 30 gauge needle. So the most commonly used dentistry is around 30 gauge needle and 27 gauge needle. So what we are using in our department one is 27 gauge needle for the long needle and the short needle. So advantage of the large needle over the small gauge needle is less deflection as the needle advances through to the tissue, greater accuracy of injection, less chance of needle breakage, easier aspiration, no pivotal difference in patient comfort. So the length, it depends on, because length what we are using is when you're going to give the block, infernal block like that, we are using that longer needle. We are using for that infiltration, we use the short needle. So shorter needle will be around 20 to 25 mm, and long needle is around 30 to 35 mm. That mostly we use the 27 gauge needle. Next one is that composition of the LA. What are the contents inside the local anesthetic solution? So the first one is that lignocaine 2%. Next one is the vasoconstrictor, that is adrenaline 1 is to 80,000. That concentration will be varies, it depends upon the solution. Then the reducing agent is sodium metabisulfite. Preservative is methyl paramin. So we want to preserve for long span. We use the methyl paramin. Otherwise, we don't use. If you are using immediately, that means there are different types of bottles we are using. Single category is there, and vial is there. Vial means around 25 ml will be there. So we can use multiple times. In that type of solution we need param, because we after one day if you use and the solution will be in that, so then next day if you want to use, definitely we need preservative. So single cartridges, they will never use that much amount of preservative, because we are using one patient and discard it. Isotonic solution is sodium chloride, fungicide is thiamine, diluting agent is the distilled water. These are the composition of local anesthesia. So, what are the types of local anesthetic agents? So, there are a lot of types we have, but normally used is lichenocaine. So, what we are seeing, not in Malaysia and talking about the entire world, we are using like procaine, lichenocaine, uh, then bupivacaine, articaine, like that. The procaine, this is a classification of under ester 1, and the excretion is more than 2% change in the urine. Vasodilation properties is produce the greatest vasodilation for all currently used in the local anesthesia. Onset of action is 6 to 10 minutes. The action will start very fast. The effective dental concentration 2% to 4%. The anesthetic life will be around 0.1 hour. The topical anesthetic action not clinically acceptable for this type of concentration. Next one is that lidocaine, that's so commonly used, but nowadays in Malaysia, what we got that the lidocaine that is already stopped production in Malaysia. So we are using other types. So lidocaine is very safer one. The patient don't have any allergic reaction, nothing like that. So classification of amide 1, amide metabolism by in the liver by macrosomal fixed function of race. Excretion by kidneys less than 10% change, like more than 80% will be varies in the metabolites. Vasodilation properties considerably less than those of procaine. The onset is 2 to 3 minutes, very fast acting, and effective of the dental consists 2%, is normally used 2% lichenocaine. Anesthetic half-life will be 1.6 hours, around 1 hour, more than 1 hour will get that action, 1.5 hour. So the maximum recommended dose is around 7 milligram. Without adrenaline, we can use 4.4 milligram. So there are different percentage available, previously available in the market. It is 1 is to 1 lakh, 1 is to 80,000, 1 is to 50,000, like that. So it is very safer, but not available now in Malaysia also. So the plain lidocaine with the outward second as was writing the pulpal limit pulpal action to 5 to 10 minutes. We can inject the solution in various parts, so they have a very fast acting. So that is why lidocaine is most commonly used. Next one is mepivacaine. Now in our department, what we are using is mepivacaine. Classification the same amide 1. So the vasodilation property produces slight vasodilation. Escalation by is 1 to 16% anesthetic, and dose is a great change. So the onset of action is 1.5 to 2 minutes. So it is fast acting, and the half-life is almost equal to the lidocaine, but it is slightly more than the lidocaine. So topical anesthetic action not clinically acceptable. Maximum recommended is 6.6 milligram. It is slightly lesser than the lichenocaine. Next is bupivacaine is the same category of that bupivacaine and the lichenocaine. Metabolism in the liver and amides. The main onset of action is 6 to 10 minutes. Effective dental concentration is 0.5%. This percentage will be less. Anesthetic half-life will be 2.7 hours. The action will be more. The maximum recommended dose with adrenaline is 1.3 milligram per kilogram body weight. Next one is that anesthetic solution for the topical application. There are already mentioned the last time that regarding solutions are injectable is there, topical is there. So topical one, what we are using, the topical LA, what we are applying is the benzocaine. It's a course available in water, not suitable for the injection. Localized allergic reaction may occur, but it's very rare. Reported to inhibit the antiviral action of the sulfonamides. Next one is that we can sulfate is that is a substitute for the cocaine, the topical anesthesia of the eyes, ear, nose, throat, ear, nose, and throat. Twice the anesthetic potency of cocaine, but it's 2 or 3 times more toxic than cocaine. Not good, suitable for the injection. Recommended dose is around 5 ml or 4% solution, which is not exceeded. Next one, lignocaine. Lignocaine, the commonly used one, but for our department, what we are using is that ibuprofen, benzocaine. Uh, Lignocaine is normally used in that general anesthesia or giving for that normal surgical procedure. They will apply topically is lignocaine. It's available in the form of topical application of lignocaine base and lignocaine hydrochloride. Lignocaine base is which poorly soluble in water, used in 5% concentrate indicated the ulcerated, abrated, and lacerated tissue. So when you have any topical, that means a patient have an operation like that, now we can use the lignocaine base. It is very fast acting, so we can clean that wound everything very fast because its action is be more. Lignocaine hydrochloride, which is available as the water soluble preparation using 2% of concentration, penetrates tissue more effectively than the base form. Greater risk of the toxin than the base form. So these are the local anesthetic agents what we are using normally. Lignocaine mostly used for the discharge and anesthesia procedures. Uh, that is 2% commonly used. Benzocaine is normally used what we are using for the topical anesthesia. So these are the main things what we studied in the local anesthesia. Next class we are discussing about that techniques of local anesthesia in maxilla and mandible, and later on we'll discuss about the complication of LM.